Good morning, everybody. This is Major Raul Amin. I'm the program director for the psychiatry residency at Walter Reed. Thank you for visiting this particular topic. On my team today, you'll also hear from Captain Lee Hirt. He is one of my residents, and he'll be starting his senior year this coming academic year. And also on this topic, we've had collaboration with Major Skiles, who's a behavioral health officer and has significant experience in this area. So this topic is part 2 of a 2-series discussion. So please do check out our topic on administrative separations for Army soldiers. This one is going to discuss medical board. So we don't have any conflicts of interest, financial or otherwise, and anything that we discuss here are purely our own personal opinions and not that of the Army or our institutions or anything else, any other entities in the U.S. government. These are our learning objectives. So we want you to be able to list psychiatric conditions that are appropriate for referral to medical board. And we're going to refer to medical board as MEB at times. We also want you to be able to know what procedures are required to put together a medical board packet when a soldier has reached medical retention determination point, MRDP, and we'll be discussing what MRDP is. We also want you to be able to be familiar with and describe special rules that have to do with service-related post-traumatic stress disorder. And we also want you to be able to describe Army policies, specific policies that govern regulations related to MEBs. Obviously, those would be important reference policies for you as you conduct these. And finally, we want you to be able to demonstrate when you should consider admin SEP or administrative separations over MEB. And so this is why it's important to also review our topic on admin SEPs because in order to effectively do medical boards, you need to be familiar with admin SEPs and vice versa. So when should we refer people to medical board? Well, when there are specific medically boardable conditions that are present, and those specific conditions we will review. Here's the Army Medical Department policy portal. So if you work for a military treatment facility and you're either active duty provider or a civilian provider with a CAT card access, you should be able to go to this link and be able to download any of the medical command policies. So, so before I go into when to refer medical board, I just want to give sort of a big picture overview. In the Army, soldiers who are not able to do their job, maybe due to a medical condition or a mental health condition, or it may be because of conduct problems. And so those soldiers have to be separated through some avenue. One avenue is to essentially separate them administratively. And so under administrative separations, we deal with certain conditions that have to do with misconduct. So let's say someone is abusing cocaine or using cocaine, they are going to be separated through legal administrative channels from the Army. And then someone, let's say someone has some medical condition, they end up with a brain tumor and that has to be excised and now they can no longer function. Well, that's sort of an easy one, right? So you would separate them through the medical channels and they'll receive an MEB or a medical board. In behavioral health and psychiatry, sometimes it's not clear cut. So what do you do with someone who is caught with a misconduct, who has a personality disorder, for example? So should personality disorders be administratively separated or medically, even though it's technically a DSM diagnosis? The current policy and standing in the Army and other, DoD services is that things like personality disorders are not medically boardable condition and they are administratively separated. Adjustment disorder is an administratively separated condition. Failing substance abuse rehabilitation efforts is an administratively separated condition, or administratively separated condition, and it needs to be dispositioned through those administrative channels. However, most other conditions in DSM-5, such as major depression or any of the unspecified depressive disorders, any anxiety disorders, PTSD, bipolar, schizophrenia, and other psychotic spectrum disorders, all of those are considered medically boardable condition, not any different from someone having a brain tumor, let's say. And so those have to be, those soldiers that are not able to function because of that medically boardable condition have to be dispositioned through medical channels. And so when I say medical channels versus administrative/legal channels, there are consequences for the individual soldier. If you medically board someone, often it's associated with benefits, financial benefits, healthcare benefits, and other educational benefits sometimes. When you administratively separate someone, then those benefits may not be there, or usually not there. Other consequences for the unit are that admin SEPs tend to happen very quickly. Medical boards at the present moment may take up to a year. It could be 9 to 15 months, depending. So medical boards are done when someone has a medically boardable condition, which is causing them dysfunction. So that's the big picture. And so anytime you're trying to admin SEP people, which if you check out our other topic on admin SEPs, you'll see that the burden is on us to prove that that individual does not have a medically boardable condition. And when a medical boardable condition exists and the dysfunction is due to medical boardable condition, that always takes priority. And so this comes from AR 40-501, Chapter 3, which has to do with retention as opposed to accession. So accession rules have to do with who is able to join the Army. When you're a civilian and you want to join the Army, you're going to look at the accession standards that tend to be actually higher, more strict. Retention standards, on the other hand, says you need to be able to do X, Y, and Z. And if you're not able to do X, Y, and Z, then you have fallen below the threshold of retention. And then that individual is deemed to be at medical retention determination point. So we'll go through all of that, but this is sort of a big picture. So today in this topic, we are purely talking about medically boardable conditions. And so these are the medically boardable condition. Pretty much everything in DSM, including chronic adjustment disorder. Acute adjustment disorder is ADSEP. Chronic adjustment disorder is medical board, and then the rest. And so personality disorders are not medically boardable conditions. Substance use disorders are not. ADHD, impulse control disorders, those are not. And then the big one is acute adjustment disorder. But everything else is medically boardable conditions. So this is what we have. Neurocognitive, all of these essentially are. So what is probably helpful for me is to remember what is not medically boardable condition, which is acute adjustment disorder, personality disorder are the big ones, and then substance use disorders, ADHD, impulse control disorders, and the paraphilia diagnoses. This is what AR 40-501 says when we talk about that threshold of not meeting medical retention standards. So what is disqualifying? The soldier has duty limitations and impairments, essentially. They're unlikely to, they can deploy, and they're not likely to recover within a year, essentially, are the big ones. So, so this is, we summarize this well on slide 10, which we'll go through in a second, so it'll make more sense. The big thing in orange here is that that this is your opinion or your judgment call when we talk about someone who will not recover in a year. It's something that you can prognosticate and form that opinion, 6 months into someone's treatment. So let's look at some of these definitions. So medical retention determination point is soldier no longer meets retention criteria. So the minute you think that Specialist Smith is not able to meet the retention criteria in Chapter 3 of AR 40-501, that individual is at medical retention determination point. And we're specifically talking about behavioral health, but this could be true for someone with knee pain or chronic low back pain or other physical ailments. So an individual is at MRDP if the dysfunction relates to a behavioral health diagnosis. That impairment is causing them duty impairment or duty limitation. So let me define this. So this is an important element. Duty impairment is dysfunction that is caused by the actual medical condition, such as depression. So depression can cause people to have apathy, anhedonia. They don't want to do anything. And let's just say a soldier has to do this cognitively heavy work, and the depression is preventing him from being able to focus on his job. And he's not able to do that, and it's causing him a lot of problems at work. His boss and supervisors unhappy with him. So that would be a duty impairment. A duty limitation, so duty impairment is what the disease or the disorder does to the patient. A duty limitation is what the system does to the individual patient. Duty limitations are all the administrative rules that means that if you have depression and you have suicidal ideations, then I am going to limit your duties by putting a temporary profile on you. And it's going to say that Specialist Smith cannot carry his firearms. And now I have limited you in terms of what you can do administratively. There are also other rules that have to do with who is and who can and cannot deploy to the central command area of operation, let's say. And so we have mods 15 now that essentially raises the bar even further in terms of how fit you have to be physically, mentally. And if you have suicidal ideations, then you are not able to deploy to central command area for a year. And those are just the rules. So the rules itself are now causing you limitations. So a medically boardable condition like depression can cause you either duty impairment or duty limitation, and you just need one or the other. You don't usually people end up with both just because the way it works, but you only need one or the other. You don't have to have both duty impairment or duty limitation. There's one instance where you need both, and that is if you're medically boarding someone for chronic adjustment disorder, you need both duty impairment and duty limitation. So that's something that's important to know. So this individual have to have a medically boardable condition, which is causing them duty limitation or duty impairment. And then you have given them a reasonable opportunity for treatment. So if someone has depression and they have had 3 different types of medication and they have been in individual therapy for 6 months on weekly basis, and even ended up in the IOP, in the intensive outpatient for a month, and they're still not able to function, then you have checked the box on reasonable treatment opportunity. And this is somewhat of a judgment call in terms of what is considered reasonable. But so you'll have to use your own best judgment. And then the prognosis is poor. So this is another judgment call where you say this individual is unlikely to return to full duty within a year. And if you have all of those, then all of a sudden you're at MRDP, which means that you are going to refer the individual to medical board. ITIS, you'll hear the term ITIS a lot, which is Integrated Disability Evaluation System. So this is a joint DOD and VA process, and they concurrently evaluate an individual who has at MRDP and has been referred to MEB. And so this is sort of outside the scope of this, but those individuals that are referred to medical board work with ITIS in order to finally end up with some sort of disability ratings, and they determine what sort of benefits they're going to have, and they also end up ultimately receiving their discharge orders from the Army. Okay, so this is my last slide before I have Captain Hert discuss the remaining portion of this talk. But this is probably the most important one, and you may want to do a screenshot of this and save this, but this is the algorithm. So if you know this, you can do a medical board. Okay, so we're going to start off at the top. And the big question is, okay, so you are a provider, you determine that a behavioral health condition are starting to interfere with an individual's performance. And so the first question you're going to ask is this behavioral condition, is it eligible for ITIS, or I would use the word medical board? So the purposes of this, let's just go ahead and say yes. So let's just say the patient has major depressive disorder. Yes, that is a medically boardable condition. So we're going to go to the yes column. The next question is the individual having bipolar 1 or they have a chronic psychotic disorder such as schizophrenia? But it doesn't have to be schizophrenia. It could be schizoaffective disorder, any of those. If an individual, you meet them for the first time, is day one, and you realize that they have bipolar 1 and you diagnose them with that, or they have schizophrenia, let's say, then it's an automatic med board. You don't have to go through any of these other steps, and you'll go ahead and refer them to med board. Because the prognosis of these conditions is so severe that we are not even gonna try various interventions. So from the active duty side, we think these individuals belong in the VA system in order to return back to function, but they should never deploy and they should no longer serve in the Army. If it's not bipolar disorder, so in our example, we're going to say major depressive disorder, we're going to ask ourselves, do they have duty impairment or duty limitation? And in this case, the individual is not able to do his job because of cognitive issues. And so then yeah, that is a yes. Do they have chronic symptoms and or poor prognoses? And we think, yeah, so in this case, let's just say the individual has had depression throughout his life and it's recurrent and it keeps on happening. And so we think that the prognosis is going to be poor. Has the individual soldier been given sufficient amount of time and opportunity, such as treatments, to recover? And then in this case, as I mentioned, for example, that they've had 6 months of different 3 different meds and individual and IOP. And so we feel comfortable from an ethical perspective that, yeah, we have given this soldier every opportunity we could. And so the goal of these processes is medical readiness. We're not in the business of trying to kick soldiers out, but there are certain soldiers whose prognosis is so poor that we need to help them disposition from the Army so that the unit is able to get another soldier who is able to do that job, because the unit has to maintain its readiness. And if there's an individual who is not able to do his job, we can, we don't have an infinite amount of time. And so we have to help the individual along towards moving to civilian life while we are able to replace that soldier with another soldier who is able to do his job. So all of these decision points are meant to reinforce this idea that we want to give this individual every opportunity, because we're in the business of returning soldiers to duty and not necessarily med boarding them out. But when a soldier needs to be medically boarded, then we need to be prepared to execute those procedures. So finally, in the green box there, what you do is, in order to initiate medical board in the Army, we have the EProfile system. You can have a profile on a soldier that is temporary. So you expect that condition to improve. So you put them on temporary profile, you treat them, and then they recover back and they're back to duty. So let's say someone hurt their knee, you want to give them rest for a month or something like that. They get put on a temporary profile and they move along with their career. But if whenever you have someone that needs to be medically boarded, then they end up with what we call a P3 profile. But specific with this is, you may hear the term S3 profile, and the letter S signifies a psychiatric profile. So going into e-profiles and that sort of thing is kind of outside the scope of this, but you'll go into e-profile and you'll submit a permanent profile. That permanent profile requires a second signature from an approving authority. So that is sort of a check and balance. We want to make sure that we're not willy-nilly med boarding people from the Army, that it's done in a deliberate and methodical way, and that all the appropriate steps have been taken care of, such as on this algorithm in in the yellow. And so then the approving authority will probably discuss the case with you. Often in a lot of organization, you might email them and say, hey, I'm going to send you this case. This is why I think that they are at MRDP and they need to be referred to medical board. So you don't want to surprise the approving authority with a profile pending. So you ideally want to go ahead and let them up front discuss the case with them, and the approving authority is usually someone with a lot of experience doing this sort of thing, and they might be able to mentor and coach you on the process. So that is how you end up with an MEB. Anytime there's a no, you can go ahead and read through the ITIS referral is not appropriate. And then if you're unsure, you can look at the box on the left side. So with this, Captain Harrod, I'm gonna have you take over from here, and I'll put myself on mute.
All right. Thank you, Major Amin. So when to refer for medical board, we're going to start by going through an example case based off of the algorithm that we just reviewed. And the first case is a 23-year-old married Caucasian male, active duty U.S. Army E4, with 3 years time in service, no deployments, and a past psychiatric history of ADHD, generalized anxiety disorder, and childhood emotional abuse. He presented to behavioral health 12 months ago for growing anxiety at work. He worries about making mistakes, being late, and feels very anxious when speaking to superiors. He's also worried about family well-being, especially after finding out that he is pending an unaccompanied ACONUS assignment. He completed IOP for anxiety 6 months ago and has continued with weekly therapy since. 3 medication trials have provided only mild symptom relief, and command reports that they cannot rely on the patient. Commander asks for your recommendations since your EProfile blocks ACONUS transfer. So reviewing basically from the provider's perspective, the algorithm and why we made our decision of this case supporting a medical board, we can kind of go through, does this individual have an IDES eligible diagnosis? And yes, this individual does. Do they have a bipolar or psychotic disorder such as schizophrenia or schizoaffective disorder? No, that's not applicable in this case. Is there documented or concerns for impairment in the service member's work responsibilities? And yes, the command has relayed to us that the individual is not performing their job adequately, and he can't go on ACONUS due to the high risk of decompensating. So this supports MEB or MEB. Chronic symptoms, 12 months, but likely longer, yes. Poor prognosis due to his history of childhood abuse and trauma, and lack of response to treatment, yes. And then was he provided the ethical or full treatment opportunity and trial for treatment? Yes. So he was given IOP and 3 medication trials, and none were adequately able to control his symptoms. So to recap, for the first objective, we wanted the audience to be able to list psychiatric conditions that are appropriate for referral to medical board. And so I won't read that list because we've reviewed it a couple of times now, but we would look at the left side of that earlier algorithm or to these disorders below in the list from Chapter 3 of AR 40-501. So how do we make a MEB packet? Well, we would want to evaluate the current symptoms like we'd done in the previous case example, history, and using clinical judgment prognosis. We would identify the primary cause of the impairment. In the previous example, it was generalized anxiety disorder. And then we would want to know if the individual met MRDP or qualified to go to an MEB process. And so he didn't meet retention criteria based off of IAW AR 40-501 due to the generalized anxiety disorder. Next, the clinician, we would have to inform the service member, explain what IDES is and the likely process going forward, and perform a risk assessment. And then we would initiate permanent profile. And lastly, we would inform the service member's command of the decision and the duty limitations recommended, such as non-deployable or restricted or no weapons access. We would continue treatment during the process until the MEB process is completed. At this time, it takes roughly about a year. Let's see, initiating the S3 profile and E-profile. If the soldier needs duty limitations due to a behavioral health condition, we would submit an E-profile online, and this would be the permanent one discussed earlier for the MEB process. And then to review, we would call or email the commander if clinically indicated, and review any safety concerns. And below are the links to how to submit or where to submit this S3 profile, with a tutorial provided as long as you have CAC access to assist in doing so. How do we communicate with the command? So we would want to inform the commander of the decision and duty limitations. And, oh, that was short. So we will review or recap with objective 2. And our hope through those last few slides was that we would be able to demonstrate the procedures required to put together an MEB packet for a soldier and who is at medical retention determination point, MRDP. So moving forward, MEB packet exceptions. Service-connected PTSD rules are something that we should make a footnote of in this process. Somewhat similar to chronic adjustment disorder versus acute, there are some special rules associated with service-connected PTSD. If a service-related PTSD is ever diagnosed, behavioral health providers, we cannot recommend ADSEP for any behavioral health condition until after IDES finds the soldier fit for duty. Based off of DoD 1332.14, MedCom policy 19-001, if there's concern that soldiers with service-related PTSD could possibly be inappropriately separated, that's why we have this process of extra review through IDES. And to further describe this regulation, it states, unless found fit for duty by the disability evaluation system, a separation for personality disorder or other mental disorder not constituting a physical disability is not authorized if service-related PTSD is also diagnosed until that IDES evaluation is completed. Objective 3 recap. To review what we had just went through there, we wanted to be able to describe the special rules related to service-connected PTSD when considering an MEB for a soldier. Why MEBs happen in Army policy review. So what makes a soldier non-deployable? We've reviewed. And then Army Directive 28-22, paragraph 4A, states that a soldier is administratively, legally, and medically cleared for employment in any environment in which the Army is operating or could operate. The soldier can carry and employ an assigned weapon. The soldier is capable of executing all individual warrior tasks for his or her assigned mission. And then a recap again of 40-501 in Chapter 3. To be deployable, soldiers should be ready to deploy within 72 hours of receipt of an assigned mission as defined in Army and DoD policy. So essentially, if we don't meet these points under Army Directive 2018-22, paragraph 4A, this would make the soldier non-deployable. And again, the disorders on the left-hand side of the earlier algorithm that we've already reviewed from 40-501. To further define what Army Directive 28-22 is, I'll read some quotes. It states that commanders and leaders at all levels are responsible for individual soldier readiness and will use available tools, resources, and authorities to reduce the number of non-deployable soldiers within their formations. And here is just a copy of that memorandum from 2018 with the same quotation highlighted. So in review, or further review, it's important to note also that there's another regulation referred to as Centcom Mod 14, which states that combatant commands have their own medical standards of fitness due to differing mission requirements, and policy informs each individual behavioral health provider assigned to these service members when to submit a waiver for behavioral health related issues to the Centcom surgeon. So these Centcoms differ due to geographical or functional missions and are divided into combatant commands, and there are several. So I won't read these off, but throughout the planet, Centcoms are divided up into combatant command. Okay. More recently, as you can see in the bottom right-hand corner, Mod 15 has been released, but there have been no significant changes. In further defining Mod 14, individuals possessing a disqualifying medical condition must obtain an exception to policy in the form of a medical waiver prior to being medically cleared for deployment. An example would be a patient pending deployment to one of those previously reviewed sitcoms, and the behavioral health provider would determine whether the patient can deploy from a clinical perspective and submit a waiver. And then it would have to go to the Centcom surgeon at each one of those combatant commands for their approval of the waiver before the service member would be allowed to go. And this is just a review of Mod 14. The actual quotation is highlighted. Okay, objective 4 recap. Participants will be able to describe the specific Army policies governing regulations related to MEBs. The top 6 Army policies for behavioral health providers in review is Army Directive 2018-22, which provides a definition of what being deployable is. AR 40-501, Chapter 3, the lists of behavioral health conditions that are eligible for MEB. AR 635-200, which is the general guidance on administrative separation or ADSEP procedures, and MedCom policies 19-001 and 010. These provide the 3822 guidance for behavioral health providers and give information on how behavioral health providers can upload administrative separation packets to BHAR, BHAR. And MedCom policy 17-079 is the e-profiling guidance recommended for duty limitation. And then as we're nearing the end of this presentation, in the first part of this series that Dr. Amin mentioned earlier in this lecture, there was an entire different lecture that goes over in greater detail ADSEP or administrative separation. But at the end of this, we would like to recap under this lecture as well a summarized explanation of the difference between ADSEP versus an MEB. And this is a very simplified review of both, but a medical evaluation board is basically defined by IAWAR 40-501, and that's when a soldier is non-deployable for 12 months from the start of treatment, and they were given an adequate trial of treatment in an ethical fashion and still did not improve. And then ADSEP, the soldier no longer meets retention standards based on AR 635-200, and that's when a soldier is no longer able to perform work satisfactorily despite treatment for such things as acute adjustment disorder or personality disorder from a behavioral health perspective. And when would we initiate these? So we'll give an example case of when we would initiate an administrative separation versus an MEB. So similar case as before, some slight modifications to the clinical vignette. So this is a 23-year-old married Caucasian male, active duty U.S. Army E4, 3 years time in service, with past psychiatric history of ADHD and generalized anxiety disorder with a history of childhood emotional abuse. He presented to behavioral health 12 months ago for anxiety at work. Due to his ADHD, the patient makes frequent mistakes and command has considered an administrative separation for poor performance. And the patient is also worried about his family's well-being since he's possibly being sent unaccompanied on an ACONUS assignment. He completed IOP for anxiety 6 months ago, and after weekly therapy, generalized anxiety disorder is well controlled. 3 ADHD medications were trialed and have only provided the patient or the service member with mild symptom relief, and command cannot rely on the patient due to frequent mistakes at work. The commander asks for your recommendations since the quality of work has not improved with counseling and treatment. So we would review, similarly to the earlier algorithm, what exactly constitutes, when you're asking yourself as a provider, reasons for an administrative separation versus an MEB. So we'd go to the top portion of this algorithm, highlighted in orange, and we would see that the behavioral health condition would have to have symptoms significantly interfering with the assignment or performance of the military duties, or interfering with the service member's ability to deploy. And then we would look at the contributing factor or primary cause of the poor work performance. And we would ask ourselves, is there impairment, significant impairment, or need for duty limitations? And if there is, or seems to be, and we're not sure, we would go to the left-hand column and we would look through AR 635-200 at the specific disorders from a behavioral health perspective that might qualify for administrative separation. And then if there is one, such as adjustment disorder, acute, or personality disorders, we could move forward and we would review if the soldier has a poor prognosis from a clinical perspective. And then lastly, similarly to an MEB, we would want to provide the service member with an adequate trial of treatment, because we're not in the business of trying to kick out service members if we can avoid that through offering behavioral health intervention. However, if there isn't adequate response, then we would proceed with the administrative separation. And similarly, we would inform the command of the service member, and then we would submit an ADSEP packet. And we would fill out a form 3822, which goes slightly beyond the scope of this lecture, but it's a form that would be provided to the command of the service member, discussing basically duty limitations and recommendations from a behavioral health perspective for the individual, and also list the diagnosis and prognosis of the service member from a behavioral health perspective. Okay. And then reviewing why this individual with the slightly changed clinical vignette meets administrative separation criteria. We can run down this list. So looking at the algorithm we saw before, is this individual ITIS or MEB eligible? And the individual has ADHD, so they do have an eligible diagnosis according to ITIS. And then is this individual, do they have a psychotic disorder or bipolar? And the individual doesn't have either one of those in particular, but they do have ADHD, so they technically meet criteria. Is their impairment significant enough that it's noted at work? Yes. Command cannot rely on this individual due to mistakes at work. And then are there chronic symptoms? Yes. And poor prognosis would be also yes, due to the lack of response to medications. And was proper trial of treatment given to this individual? Yes. 12 months were given without noted significant improvement in the impairments noted at the service member's work. And then reviewing AR-635-200 quickly. This is a regulation that ensures the readiness and competency of the force while providing for the orderly administrative separation of soldiers for a variety of reasons. And then the separation policies and the regulation promote the readiness of the U.S. Army, and the behavioral health provider would base their clinical judgment off of reports of the service members' conduct and their ability to meet required standards of duty, performance, and discipline. And then adequate trial of treatment should have been given to the service member with counseling, retraining, and rehabilitation prior to initiation of any administrative separation. And if the service member, unfortunately, if they don't respond, then the military service should be separated in order to avoid the high costs in terms of pay, administrative efforts, and degradation of morale and substandard mission performance that could occur if an individual that's incapable of performing their duties remains in the service. A quick recap of Objective 5, and it was our hope through those last few slides that participants would be able to demonstrate when to consider administrative separation over MEBs for a psychiatric condition, and for misconduct proceedings as well. And here are our references, and I'll pause for Dr. Amin to enter back into this discussion to review further.
Thank you so much. So I think that if this is your first time being exposed to these concepts, I imagine that they can be overwhelming. But the intent is to kind of give you broad overview, some cognitive checklist using those algorithms. And then when you're ready to do your first medical board referral, highly recommend that you work with a mentor or coach who has done these before, and they'll be able to kind of walk you through step by step. And after having done a couple of these, I think you'll have sufficient confidence and sufficient knowledge, skills, and attitude in order to do these on your own. The big picture is our mission is readiness. If an individual soldier is not ready due to legal reasons, then they get legally separated through legal channels. We come into play under some of the administrative separations and in the AR 635-200. And so you have to know when to send patients through administrative channels. So that would be for things like adjustment disorders and personality disorders. And so when we send them through administrative channels, it is less financial burden on the government, essentially, because it's not associated with any healthcare benefits or financial benefits, and it's also faster. So the unit will quickly get the soldier replaced because we're able to separate them. The caveat is that you can only administratively separate people who are not at MRDP. Now, going back to what MRDP is medical retention determination point, and that is when someone has a medically boardable condition, it's causing them dysfunction, they've had sufficient amount of treatment, and you prognosticate and you opine that they're not going to recover within a year. What is dysfunction? Well, you can have duty impairment and duty limitations. Duty impairment is just that they physically cannot function. Duty limitations have to do with some of the administrative actions we have. You know, we have these policies. Captain Hart talked about the Mod 14, Mod 15, where you can't deploy if you have certain conditions, and so all of those. All of the dysfunction happening in someone with a medically boardable condition need to be medically boarded. Anyone with dysfunction who doesn't have a medically boardable condition, or they do, but their dysfunction is not due to that medically boardable condition, but it's due to an administratively separating condition, then they need to be administratively separated. And you need to really have competencies in both. This is why we introduce the ADSEP concepts towards the end of this lecture, but please do review the other video on this in order to fully grasp this in totality. Finally, I think the slide where it provided a link to how to do e-profiles, definitely something that you need to know as a skill in order to be able to execute medical board separations. Finally, a big thing I would say is anytime you think someone is at MRDP and you're about to put a permanent profile on them, which initiates the process, you definitely want to just engage with other stakeholders. So often I might even email my point of contact at my local ITIS and say, hey, I'm about to drop a S3 profile on this individual. This is my rationale. What do you think? And they have 99.9% of the time, they agree with me. and they give me thumbs up, and then I might take that email and forward it to the approving authority for the permanent profile and say, I've already discussed this case and I'm going to send this your way. So now you made the life of your approving authority easier, because they probably get 20 profiles that they have to co-sign. So doing some of that work up front will give you greater confidence that when you submit this packet, this med board, that it is indeed going to get processed. Now, scenarios where an individual patient disagree with you, just let them know that the ITIS process itself has built-in appeal mechanisms and they can appeal it. But if you think someone is at MRDP, then go ahead and submit them as long as you coordinate and communicate with them. The other thing is counseling your soldiers. Most of the time they'll agree with you. Is let them know that you are not really per se deciding whether they should be medically discharged from the Army. Your job as a clinician is to determine whether or not they're at MRDP and initiate the process. The whole process could come to a halt if the approving authority disagrees with you and say, no, I don't think the individual is at MRDP, so I'm going to reject the permanent profile. It could also be that the ITIS office and the individual that's reviewing the packet after you submit it may disagree with you and completely bring the process to a halt. So this is why it's important to kind of do your legwork up front, communicate with someone from ITIS or your permanent profile signature authority and say, this is the case, this is what I think. And then when they get thumbs up from you, then let the patient know that, hey, I'm going to submit a permanent profile, which may lead to medical board, so that there's some realistic expectations and you don't have a soldier that thinks that they might be getting medically boarded with various benefits, etc. And then you may have called it too prematurely, and it's just therapeutically not a good thing to do with patients. So with that, these are all the comments we had. And here is our point of contact. Feel free to reach out to us if you need anything. Otherwise, thanks for tuning in. And lastly, Captain Hurt, any last comments before we end the discussion?
I have none. Thank you for being with us today, and I hope you have a good rest of your day.
Thank you all. Bye-bye.